Oral oncolytics have become a mainstay, and they're here to stay. I mean, in the last maybe 10 years, we've seen at least almost 30 drugs that are oral therapy that have come. They offer significant advantages, but there are disadvantages as well. So the primary goal really in having that conversation about what choice, whether we do oral versus intravenous, is going to be based on several factors. I mean, one would be, what are the guidelines for that particular tumor type suggest? And then two, considering what the patient's lifestyle, where the patient lives. In some areas, we're in the Northeast area where oncologists are around and it's very easy for patients to access it. In rural areas where the distance between where the patient's physician may be and where they live, where there are challenges in transportation, the oral agent may offer an advantage. However, the disadvantage, of course, may be the fact that the patients now have to take on more responsibility in their care, because now they're responsible for managing some of the side effects, issues, symptoms, and the follow-ups that they normally will get in an intravenous setting, they might lose that. Oftentimes, I've had patients who get sad because then we move from intravenous where they're in the clinic every week or every 2 weeks, and now we barely see them, and it's a month before we see them, and so they get that loss of connection in some ways. So that's some of the disadvantages that we've seen patients share with us. The other piece that I feel also could be an issue, and as a pharmacist is of a great concern to me, is the multiple drug-drug interactions. So there's a need to review every drug the patients are on in context with their other non-oncology products. So where it is flexible and is beneficial, there are complex challenges associated with using oral oncolytics. At the point of end-of-life care in making the decision about what drug therapy we should use, I believe that as many stakeholders as possible that can participate in that conversation is critical. So of course the primary oncologist, the patient and your families. If there are other members of the team, the palliative care team, who can sit in that conversation, that will be tremendously helpful. Why is that? Because we know we have to factor into cost. We have to factor into the symptom management. We have to consider the patient's cultural or spiritual beliefs about some of the side effects potentials that we can see with these agents. So as complex as these therapies have become, it is necessary to leverage all the different disciplines that we have available to us.